thank you for you two joining me this evening. This is a little different from our usual podcast. It is basically shockwave orientated, but it's on erectile dysfunction. For everyone else listened to our podcast before, it's usually about musculoskeletal pain. But a few people have asked me about whether I could tackle this as a topic, because it's ever evolving as a topic. And in North America and Europe, it's becoming much more a part of the conversation that shockwave is used for erectile dysfunction or impotence. So I know that Ben, today you'll be helping us navigate a little bit of the mechanisms and some of the research along with Yves. And this is slightly unusual because we've got three of us on here, because I thought that was the best way to do it. So for all the listeners, bear with a few mixed words. We'll try and make it as clear as possible. So for those people that are listening in that haven't come across this as a concept at all, this is based on the idea that shockwave is known to improve vascular supply efficiency in health. So it was used back as probably 15 years ago now. Some of the first trials were 2010. And the idea is that it's treating organic or vasculogenic erectile dysfunction only, not the psychological causes or anything else. But the vast majority of erectile dysfunction is vasculogenic. So those patients that are at risk of general vascular poor health, those with high blood pressure, hypertension, cardiovascular disease, high BMI, high cholesterol, or history of cardiovascular disease, and smoking, of course, those patients have poor vascular health, and the penis and its ability to engorge is one of the first symptoms you get with that. So, in terms of how it actually works as a mechanism with shockwave, Ben, can you give us a bit of insight as to the proposed mechanisms and some of the proven mechanisms?
So thanks, James, for inviting on the podcast. So like most things in science, it's a trial and error, and people always push the boundary. So while I was reading up on the research, I think they tried this on animal studies for cardiac function. Like people, they created heart attacks in, I think it was pigs, and they did shockwave, and they found it increased your vascularity and reversed some of the damage. So that led to the hypothesis. So if it could help in heart attack, it could have a similar effect on the penile structure. Because if you look from you rightly pointed out that it could be a precursor of heart function. So if you look at the artery size in the penis, it's around 2 to 3 millimeters, whereas in the heart it's 3 to 4. So it's much smaller. So if you have any heart, cardiac dysfunction like diabetes, smoking, the first area you're going to get that function is definitely from your penis. So it's nothing to be laughed about. It's definitely something patients have to take seriously. And also that's one of the things we always encourage in the ED clinics, is to have a thorough investigation of basic stuff. Like I would say most men after 40 should be doing it anyway, like blood pressure, your cholesterol, your basic blood markers, your blood, all the sort of things you would want to reduce your risk of stroke. So those factors are really important. So when you talk about the mechanism, so what has been shown first is it improves endothelial function. So, in a very simplistic way, it improves your vascularity. And we know that neogenesis happens anywhere from 8 to 12 weeks. So the patients are going to see the improvement usually by the 4th session. But I say to patient, it takes a good 8 to 12 weeks because new blood vessels take time. And the good news is it's been shown if you have access to, I do ultrasound, but I don't do penile Doppler ultrasound, which is basically a specific type of ultrasound to look for circulation. So studies have shown, like once you've completed ED, there's an increase in vascularity as shown by a non-invasive tool like a penile duplex Doppler ultrasound. So clearly there's a big effect on vascularity by new blood formation, new arteries. That could be one of the things we know with shockwave is there's an increase in nitric oxide, which is important for vasodilation. That's been shown in many studies in MSK. So, and that's how one of the ways Viagra works is that nitric oxide release. So there's definitely that nitric oxide effect.
Sorry, Ben, was that you mentioned, was that Viagra? So
Viagra, yeah.
All the medications have that common theme to them, is that they?
Yeah, they have the common theme to really improve nitric oxide production, which is basically nitric oxide is produced by your endothelial cells, which sort of gets that local blood flow going.
Right.
So you could say it has a similar. So if somebody had a good effect with Viagra, then you know that they're going to have a good effect with shockwave. So it's a good predictor.
Right.
That so if somebody had zero effect with any of the medication, so more and more studies have shown, like in some chronic cases and severe cases, a combination of shockwave and medication might be a best option rather than just purely. It's not this or other. Some people definitely need drugs, and we know that those group, sulfonylurea, that group works about 50 to 60%. So it's not a bad drug. It's been around since 1998. Viagra, I think, came at 1998. So it sort of has a vascular effect, and the nitric oxide also helps. And there is also some effect on the nerve regeneration. We know that from studies on patients who had surgery, like prostate surgery, they have nerve damage. And there could be a neurological regeneration effect, which could sort of also help that in the performance side as well. So in a simplistic way, the way to explain is improves endothelial function through increased nitric oxide, angiogenesis, more blood flow, takes 8 to 12 weeks, a good response in people who already had some response to some of the drugs, and there might be a vascular effect as well. So fortunately, we have got trials which have done sham control, placebo control. So I don't think it's just a placebo, or because they've done studies where they've done on just dummy machines with just making noise. So so there's a real physiological effect which has been shown with a penile duplex ultrasound as well. So we can measure blood flow in trained hands to see the changes in the vascularity. So the point I would raise, which you mentioned, is actually we are treating it organically, and we're improving the structurally. So it's not like just popping a pill or putting an injection. So a lot would argue that actually you're treating the structure at a fundamental level, which is more lasting than just putting like a band-aid. So that's more attractive to patient. So you're improving it from a structural level.
Is there any evidence that one of the mechanisms you sometimes read about that's proposed, I guess, is that it can help break down some of the atherosclerotic plaques in the arteries? Is that still proposed, or is there any evidence that might actually be happening?
Not really, because I think what it does is it improves collateral circulation. Like when you have a heart block, you develop collateral circulation. There is no direct evidence it breaks down plaque. So I think it's more about the great thing about the human body is it can develop. It's like when you have blocked arteries, you start walking every day for about 3 months, your body will produce new blood vessels around it and bypass the block. So I think that's what, in my opinion, is happening, because when we scan people with penile in the studies, they've shown increased vascularity. So the plaque might remain, but it doesn't matter. The body gets the circulation in a different route, bypass route.
Okay, fine. Yves, I know you treated a number of patients with this, and Ben just talked a bit about the neural regeneration. So could you just help those people that are listening exactly? I mean, it's rather obvious where you put the probe, the focused shockwave, particularly because that's got more of the evidence. Can you just tell people a bit of a summary about where you use it on the penis, and indeed where you might use it in the region of the pudendal nerve?
Sure. Yeah. So I tend to stick to the stored sort of protocol of using about sort of 3,000 impulses. We divide that by doing 2,000 on the shaft, focusing on the base, and then the top of the shaft, and then also doing about 2,000 impulses, and then treating each crura with about 500 impulses on each side, making sure that everything is covered in the whole of that region there.
Okay.
So patients, tolerate that extremely well.
What sort of energy levels do you go to? Is it tendinopathies? You take it to a point where it's not uncomfortable, but they're feeling it? Is it guided by the patient?
To a degree, it's always based on tolerance. So when on the first session, I will start at a really low setting, communicate with the patient and gradually build it up, ideally to about sort of 0.25 millijoules per square millimeter, as that's been, shown within ED to be one of the best sort of levels. Depending on tolerance, then obviously, you could go higher if you wanted to, but there might not be necessarily any kind of greater effect by doing so. There's also a couple of studies who've actually done 0.15 millijoules per square millimeter and still had good effects.
Yeah.
So Also, we tend to typically do, 6 sessions over 3 weeks, so 2 sessions per week.
Okay.
Which I think
is that based on patient preference? Do you find that they want to get it done quite quickly, or have you found anecdotally that you get a bit of response that way?
I think there has been a few studies to support that sort of protocol.
Okay.
But again, I must say that, due to logistics of patients attending the clinic, that some deviated from that, because this is still sort of a treatment that's not available in a lot of places in the country. Sometimes people travel, 2 to 3 hours, for a treatment. So to do that twice a week can obviously logistically be virtually impossible. So with those patients, I've just done a single session per week and still have had a really good effect. So, so I think from a practicality perspective, I think, ideally you want to be doing those 6 sessions over 3 weeks, but I think you need to be governed by, overall logistics and working with your patient.
Right. And so some are, I know some clinics, because we do it in clinic here, my physio does it, that some clinics will use some of the scorings that we might talk about in a minute to assess severity. And then they might say, look, actually, I think you need 12 instead of 6 or whatever else. What's your take on, both of you, I asked this to, so what's your take on whether you go straight in and say, I think you need 6, or do we say, we try 6, let's see if you are a good responder, and then it's worth, quite frankly, in private practice, paying for another 6 if you want more of an effect? How have you navigated that? So 6 versus 12, etc.
Yeah. So what I tend to do is at the start of my assessment, all patients complete the International Index for Erectile Function score, which is a very easy 5 questions, which basically can classify patients into having no ED, mild, moderate, and severe ED. Okay. I also use the erection hardness score, which is more of a visual thing, and can be quite easy to identify where people are within that. So it's a very quick way of being able to assess exactly where they are. And then I tend to have the sort of typical conversation, with patients to say that if they got mild to moderate ED, they're more likely to be okay with 6 sessions. Yeah. If you look more at moderate to severe ED, they may well need 12 sessions. Yeah. However, I've had patients with severe ED who done well after 6 sessions. So it's not always a given that they have to go for the 12. Yeah. So I tend to go for the 6 and then basically reevaluate, see where they are, and then we have that conversation to see whether they want to have a further 6, which, they can either immediately carry on with a treatment, or we have a slight break and then carry on after that. So, in that respect, again, you're very much looking at your treatment response in order to then decide where you go from there.
Okay. Yeah. And have you done any, because I think some of the RCTs, I'm going to post 3 papers on here after the podcast, but one of the meta-analyses, I noted that half of those were RCTs actually that were included, and most of them were doing follow-ups up to 6 months, which I think when I talk about Shockwave and teach it, one of the really compelling things about Shockwave versus certainly steroid for tendinopathies is the long-term follow-up data for Shockwave is so good. And actually, I think that some of that comes out in the research for erectile dysfunction, is that, it is quite expensive, I know, but actually the long-term follow-up studies up to 6 to 12 months are really good. Have you, I mean, you've not been doing it too long, Yves, but have you found anyone coming back and saying, look, actually it's not working after a month, it's not 2 months, or what are you putting in place for follow-up stuff?
So far, I've not had that. But then admittedly, I've only really been, working with patients for 6 months. So, there's actually quite a good study by Olsen et al. Who did, follow up 24 weeks, after their final treatment. And I think one of the statistics there was that 19%, could still have intercourse without any medication. So really sort of implying, a lasting effect, following the treatment. So, so I tend to, follow my patients up by phone 6 weeks after the last session, and then about again 3 months later. So I plan to keep following them up to a year, just personally, really, just to kind of get more anecdotal evidence of what my performance is within the clinic of doing this treatment.
Yeah. Okay. Ben, does that ring true to you in terms of ideas, 6 versus 12 sessions? And...
So the thing is, I agree with Yves that people, if you're planning to get involved, we always need a good objective score, and I use the simple IE, International Erectile Dysfunction 5 questionnaire. So as the name suggests, you only have 5 questions. So the key thing is it's spectrum. So you get sort of 5 to 25. So anywhere from 22 to 25 is normal. So if somebody is on a very severe, like between 1 and 7, I tend to go straight to 12. I find if they are pretty much, these are people with hardly any spontaneous activity, lack of morning erections, maybe they are diabetic. So I tend to go for the full 12. I only do that 12 for only people with severe ED. Whereas the moderate cases, I would go similarly like Yves, do the 6. And then, and the key thing I say to my patient is, ED is a reflection of, in many cases, it's a reflection of the lifestyle. So a common question which people ask is there top-up needed? And a couple of studies have shown that after 6 months, they've done another 3 or 4, and then there were better outcomes in a year's time. So in theory, after six months or a year, especially if they've been more on the severe score level, there is an argument that you could repeat it. And because the vascularity can change. If your diabetes is, I say to my patients, if your diabetes is not well controlled, if you don't stop your smoking, then it's not a guarantee, it might come back. So I think we need to be aware of that it's not a permanent one-off thing. And some patients might need that follow-up. But at this point, I've not had any reputation. But as I said, is similar like Yves, I've only been doing like less than a year. So we need to see that in the future. But for anyone severe, my preference would be go straight to 12 rather than 6. So I guess, so it's a different individual ways of doing it, isn't it?
I think there's also quite an important aspect that we can play as practitioners with regards to health education, because it isn't just about doing the treatment with the shockwave. Similar to anybody working in musculoskeletal health, it's not just about a tendon. It's the fact that if they got a metabolic disorder, that obviously you want to improve their health. You want to get them fitter. You want to get them stronger. You want to improve their general health, because you know that that's going to have a much better long-term effect. So I think with ED, again, as practitioners, I think we have a responsibility to make sure that, we're looking at a more holistic approach and actually trying to improve that person's overall health.
Yeah. And on that note, I think there will be a few people listening to this that say, is it within scope of practice? What sort of clinical triaging or should we be doing? I know the answer already to some of these questions, but for those people that might want to get into this, what would your advice be in terms of setting up a triage system so that they're definitely sure they're seeing patients that are right for this treatment?
I think before
other causes of ED. So what is your advice?
I think before we go straight into ED, I think you should be, in my opinion, you should be a good shockwave practitioner, because it's an extension of your shockwave skills. So ideally, you must have had exposure with radial for a year or 2, and definitely with a focused device for more than a year, because it's like if you just, I can give you an example from a physio school. Like, once you graduate from a physio, in theory, you could go for an injection course within 1 month or 2 months. But most therapists will wait for 3 or 5 years before they're going for injections and things like that. So I think this is definitely, I don't want to make it complex, but it's definitely an advanced skill.
Yeah.
So it's not something you've got a radial device. You shouldn't be really be thinking like, oh, I'm going to start it. So first, in my opinion, you should be really comfortable with all the variations of shockwave, dabble with all the MSK stuff, you're handling, and then the focus on your bone stress injuries. So once you're confident on that, then I guess it's a natural progression, because again, it's something which we are not touched. Is the evidence is clear that it favors the focus rather than the radial for this sort of treatment, because the energy levels are not good enough to create that neovascularity and agenesis with just radial. Although There've been some case studies, but none of the case studies with radial have had a placebo control or a control group. They've just been case studies.
Right.
So I think one of the things I want to make it clear is, if you're going to give ED treatment, in my opinion, and the evidence will support me, it has to be a focused device. I'm not saying it a particular company, but it has to be something which has been published, and most publications will, I would say 99% use a focused device. So if you're not confident with your focused device, then I guess you will struggle with your with the ADS. So once you got that, then I guess it's having that pathway where you get access to. So I think with ED clinics, we got a very systematic method where they could have a prior diagnosis, or we go through a set performer, give them access. We have access to in-house doctors who can do a screening blood test. So it's not like a shock and go sort of approach, really, because it's a holistic approach. So anything you would add there, Yves, on that?
No, I think that's very much what I would suggest as well. That's exactly what we need to do, is to go through that triage process before we even conduct any kind of treatment, and making sure that what we do is safe. I always very insistent on getting a diagnosis. Patients need to be seen by their GP or by a urologist, just to make sure that there's no other underlying structural or sinister causes for their ED. And then that then gives me the assurance that I am practicing safely. Obviously within ED clinics we have got the ability to for patients to be screened by one of the GPs that works for us. So which again, a lot of patients that phone up sometimes have not had that diagnosis, and once we start to sort of talk, that's actually in the first instance a really good idea to make sure that nothing else is going on. Sometimes they actually hadn't thought that far themselves. So in that way, it all fits with us being safety-minded practitioners, and that's really what I think is of uttermost importance.
And one thing I would add is to also getting knowledge on male pelvic health, or doing courses. So all of us, we have done courses on that sort of male pelvic health. So you need to have awareness and exposure, because it's looking at the holistic. They might have other disease conditions like Peyronie's, pelvic pain syndrome. So it's just not ED. So although we are just treating ED with shockwave at this stage, you need to be aware of other potential conditions which can happen in that area. So a basic awareness. So I think there's a lot of skills which need to come together.
And who is, on that note, Ben, can we just do a shameless plug of your physio colleague who is excellent at on that? And I'll put details on the podcast as well.
Yeah. So we, nearly all the practitioners from ED clinics have been, attended course from Gerard Green, who's international expert on, male pelvic health. We've decided to get the training from the best in the country. So really useful course where he goes through the whole basics of understanding male pelvic health, pudendal neuralgia, because it's a different new world, especially for somebody working like me in MSK. So if I can pick up other conditions, I'm not going to treat them, but I can refer them to other potential.
Awareness is where you should get with that, right?
Yeah.
On the subject of the research, though, because the one thing, since we started doing it in clinic and in some of the teaching, and people do, because it's quite novel at the moment, it's a very easy thing for people to say, well, it clearly hasn't got much evidence, this, that, and the other. When in fact, actually, you look at the evidence, and the evidence is really compelling.
Yeah.
And like all things that I sort of mentioned earlier, when you've got a choice for a patient to go from non-responding medication, and their next choice, quite frankly, is a pump or
injection
to the penis.
Yeah.
And that doesn't sound very pleasant. So why wouldn't you try non-invasive shockwave before that? I think that is really a no-brainer when you look at the weight of evidence. And I think that the evidence started off, as I said, in 2010 with the Vardy paper that was, I think, just 25 patients that were seen that were already responders, but they could reduce their dosage. In fact, some of them actually got spontaneity without medication. And it was always accepted that was pretty much your gold standard cohort, were those that were already responding, that could remove some of their medication when they had shockwave. And then this recent trial in 2016, the meta-analysis, and in the Palmieri trial just this year, was saying, actually, we can also pick up on those patients that don't have, that are not responding at all to medication. And they were put on medication and had shockwave, and then they allowed them to use medication and, you know, be under the control of the medication, but they weren't getting any response to the medication before. I think that's really compelling as a group of people that were definitely looking at the very severe types of treatment. Have either of you treated any? I think you said earlier, Yves, that you've treated some. Have you treated some non-responders and they've actually responded to medication?
Yeah, so I've had you know, one particular gentleman that I treated who had severe ED, and he basically went from having severe ED to no ED, you know, within his 12 sessions.
So he was non-responding to medication.
So he had tried Viagra for years and it just wasn't doing anything for him at all.
Yeah.
You know, so he then, you know, had his course of treatment, and basically he found that the change happened between the 7th and the 9th treatment. So for the first 6, there wasn't much, and then 7 to 9, you know, things started to change, and his IIEF score literally went from something like 22 to 3. You know, so a massive, you know, change.
Did that allow him to then respond to Viagra, or did he just not?
No, he just didn't need it anymore.
So he was a poor responder to Viagra.
Yeah.
The almost non-responding to a normal spontaneous erection.
That's right.
And how old? Can I ask how old he was?
He was 72.
That's quite impressive.
Extraordinary, isn't it?
Yeah. And he basically had, the thought was that he had developed ED as a result of radiotherapy. Which was, you know, quite an interesting case. But this gentleman, you know, was, as you can imagine, delighted with, you know, the result of the treatment. So again, you know, these are the kind of people that, you know, we have to keep following up, basically to see where their journey goes from here, really.
Yeah, sure. I mean, my physio colleague he's seen 4 patients in practice so far, and I mean, certainly, you know, I didn't mention it earlier, but obviously age is also an influencer on erectile dysfunction, simply by virtue of the fact that your vascular health is going to subsequently be poorer. But we had an 85-year-old in practice that was non-responding, and within 4 or 5 treatments, he responded really well. He was very comical with what he said. I won't repeat it, but he was over the moon. I mean, at 85, I mean, he didn't expect much, and he had very low, you know, not trust in the mechanisms, but he tried lots of things. He wasn't price averse, as I would say. He was quite a wealthy chap. He had been on a full journey over decades of Harley Street to everything else, and nothing had worked. And then 4 or 5 treatments into his 6 treatments, and he was fantastic.
I think practically, you know, it's such a simple treatment to give, hardly painful, quick, you know, non-invasive. So, you know, there's hardly any argument against it, rather than putting, because I can see in Harley Street, there are a lot of options like PRP injections, injections, penile implant. That's so aggressive and so invasive. So I guess you want to exhaust shockwave and your drugs first before you go into those sort of more, you know, irreversible sort of treatment. So it's sort of a logical thing for me, because hardly any people complain of any pain. A bit of soreness can be there, but, you know, nothing to really talk about. And so it's such a simple treatment that once they see it, most people are really surprised that why. So one of the guys said, like, there's nothing really, you know, I should have done it a long time ago. So we're really surprised how easy the treatment is. And effect, you know, they can feel that benefit within like 3-4 weeks.
Right. Yeah. I think that as far as my crib sheet over here looks, I think we've covered most things today. Is there anything else you wanted to say? Bear in mind, this goes out to people that are using shockwave already. Is there anything else that we're missing today that you think might be helpful for anyone listening in, thinking about doing this?
I think the one thing I would say is, like, the outcomes, like similar, like our conventional shockwave, you know, because you need the time for the neovascularization. So the score sometimes can take month by month. So I tell my patient, you're going to see some improvement usually by the 4th and 6th week. Obviously, some will have much earlier. So it's not a quick process, and the peak takes around 8 to 12 weeks for the new vascularity. And so I guess most of the effects initially is neural, but the true blood flow and the longevity there's a difference between getting a morning erection, but also doing performance without problems. So usually they get the morning erections much earlier, but able to last, that takes time. So we need to inform the patient it's not something you just zap it and then in 2 days you're able to do everything you want. So it's relatively can take time, and obviously some people are much quicker. So that's pretty much the whole story with Shockwave, isn't it? We know that it works, but it's not like an instant fix cure. So I would emphasize with people is and there's a lot of debate, especially in social media, where it's pushed as on performance element. We sometimes get queries from young men in their 18s and 20s who want to use as a performance tool, who already have good erection. So I'm a bit doubtful whether we should as a professional get involved in that, because that is not really evidence-based. If somebody already has good erection, but they want to prolong it or things like that, I won't feel comfortable in treating. What's your opinion, Yves? Is that something from a performance area? Is that something you would get involved, or have you had?
I've not had any inquiries like that, but I think again, I think when we're looking more at performance, I think it doesn't quite sit right with me as a person to start with. As you said, it doesn't become evidence based. The big problem we have as well is that these people would also probably fall outside of our sort of tools that we have in order for us to see whether there's actually a change in the treatment that we do, which then makes it very difficult for us to justify doing that sort of treatment. So, I went into this profession to improve people's quality of life, and Shockwave 4ED can improve people's quality of life. So, and I think that's an important thing. Performance, I think, is just not something that sits comfortably with me.
I agree, because those young guys, many of them are taking drugs, so I decline, because it's not really a toy to be used for. It's got a scientific purpose, and we want to treat people who have diagnosed ED for a medical purpose. It's a medical device for medical purposes, isn't it? So
perfect, guys. I think that I'll draw a line under that. I think that's been really informative. It has for me anyway, because I don't actually treat it myself. My physio does, but we have chats about this, and I think that was a nice summary of everything we've always talked about. So thanks again for joining us, and I will put on for those listeners here, I'll put on the details afterwards for the edclinics.co.uk, which I know you guys are a part of. It's got some really useful information and links on there, and the papers we talked, the research stuff, and Gerard Green's details for his courses, if anyone wants to do the course. So I'll put a link up to that afterwards as well on the podcast. So thanks a lot for joining us. Cheers.